on the front page of the Times magazine, which is a great achievement. So I think we should be proud of this, and we should definitely pat on our back and continue doing this good service we are doing, and keep doing the good work. So let's go on to our topic for the day. The first one is we're going to talk about the PPE, which is very topical. And once we get through the PPE, we'll just go briefly through the anesthetic management of COVID patients. So why PPE? Now, there has been a lot of discussion that's been going around. And also, there is a lot of confusion about what PPE I should be using when I'm going to see or manage the COVID positive patients. So looking at the PPE, what it does is it creates a barrier between you and the germs, and it also reduces the chance of touching or being exposed to or spreading any germs. So, so the million-dollar question here is, how are you going to choose the right PPE in appropriate situations? And it all comes down to the mode of transmission, and which in turn is dependent upon the droplet size. So let's get into the basics of the droplet size. Now, if you've got a patient who is COVID positive, and he's coughing, he's sneezing, and there are droplet formations. Now, these droplets are more than 5 to 10 microns in diameter, and these droplets can travel within the distance of 1 meter, and they generally don't remain suspended in air for a long time. Now, just using a normal surgical mask is good enough to filter out these droplets, but also you have to be a bit careful. Now, these droplets can spread over the surfaces around the operation theater or on the wards. So the most important thing that has come out is the hand hygiene. So you have to have meticulous hand hygiene whenever you are going to get in contact with the patient, so before and after you had a contact with the patient. And the second type of droplets, or we call as the aerosol, these are the droplets which are less than 5 micrometers. And they are generally produced during the aerosol generating procedures. We'll go on to the aerosol generating procedures in a short while, but these droplets, they can actually remain airborne for 3 hours, and they can travel for more than 1 meter in a closed space. So they are very virulent, they have a very high viral load, so they are the most infectious of all the droplets. And the best way to prevent ourselves from getting contaminated, especially the mucosa of the mouth or the nasal cavity, is using the N95 mask. So what are these aerosol generating procedures? So where are we going to have the maximum precaution, where we are going to do the maximum PPE before we're going to have a contact with the patient? And this is when you go to see a patient who is unwell, who is coughing, sneezing, but at the same time, he's given high flow oxygen. Now this can cause the aerosolization of the droplets. The other areas where we can have the same problem is when you're going to intubations, where you're going to have a non-invasive ventilation, like using a laryngeal mask. But then there has to have an inadequate seal for the aerosol to be generated. The high flow nasal oxygen, we've got the devices called OptiFlow, where they can use more than 50 liters of humidified oxygen and can be given through the nasal prompts. If you're doing jet ventilation, bronchoscopies, cardiopulmonary resuscitation, and that too even prior to tracheal intubation. So all these are aerosol generating events, and you have to protect yourself by using the best possible PPE that you have. So we just talked about the N95, that they are quite good, or they can protect you from the aerosols. So N95, where the 95 stands for 95% of this aerosolized particle, they can be filtered by this mask. But if you just put this mask on your face, is it really protect you, or is there something else you need to do or ensure to make to make sure that there is not going to be any entrapment of the air, which can have the entrapment of the aerosol, and that can cause the infection or contamination. So there are different tests that are involved. So what we call it as the fit test, and there's another one is the air leak test. So we'll go through the different videos where we will see what are the different types of tests you can do. Now, let's go with the simple leak test, which you can do yourself after you've put a laryngeal mask away. Oh, sorry, after you've put the N95. Now, once you've put the N95, what you're going to do is you're going to cover the mask with your both hands, ensuring that you are covering the maximum area. And then the next thing you will do is you take deep breaths, you inhale and exhale sharply. Now, when you're doing this, you have to focus on any leaks around the mask edges. Commonly that happens around the nose or at the chin level. So you again readjust the mask and then do your leak test. And this will ensure that you will be protected during most of the procedures you are involved with. Now, the second type of fit testing is the one which is actually used to see what type of N95 mask fits you properly. So once you've got a good fit test with aerosol, then you can keep using that particular mask for all the procedures you're going to use. Now, what we do in the aerosolized fit testing is there is a solution or the aerosol solution which has either got a bitter test or it has got some sweet test, depending upon if somebody has problems with their taste buds. So,
second nebulizer labeled fit test solution, inject. Second nebulizer labeled fit.
So this nebulizer is introduced into the hood, and the person inside the hood who's got the N95 mask then takes deep breaths. He does particular breathing exercises. He turns his neck to different directions, and he has to do certain exercise as well. And if he can't test this aerosol solution, then that confirms that the fit test is good. There is no leak around the mask. And then this person can, in future, use the same type or size of N95 mask. But then what happens if you fail the test? You can try different sizes. You can also try different types of or different makes of N95 mask. But then there are people who fail all of these, and I was the one that I failed pretty badly this aerosol testing, and then I ended up getting this fancy mask, which is a reusable mask. So it's quite cumbersome. It's not that easy to use it, and it does create a lot of pressure points, and every time you use it, you're going to wash it and clean it with soap and water, let it dry. So it increases your work when you're using this type of masks. Okay, so when we are using the PPEs, we have to look after the conservation of the PPE, because all over the world, there is a lot of shortage of the PPE. So we have to right or wisely choose the PPE we are going to don before we are going to go and manage the patients in the hospital. So about 80 to 90% of the PPE is single use, and things like your goggles or also face shields, they can be reused, but you have to ensure that you're going to do proper cleaning of these equipment. So how can we decide that which of the patient categories we will be using the different types of PPEs? So we divide these patients into the community precautions. We've got the COVID-19 patients, we've got the non-COVID-19 patients, and also we look at the aerosol generating procedures. So when you're going into the community, when you've got a good social distancing happening, only the hand hygiene, avoiding handshaking and cough etiquette is good enough to protect yourself and protect other people from getting contaminated. Similarly, if you're going to anesthetize a patient who is not positive for COVID and who's been screened beforehand, once you do the screening, you have to make sure that this patient is going to be in isolation until his surgery is done. So in this situation, you can just go with a standard PPE. You can do with a surgical mask, and there is no need for an N95 or any special mask for aerosol precaution. And then the important part is when we are going to intubate a patient who is very sick, is COVID positive, or we're going to go into certain areas, especially the ICU. Now, these are the airborne precautions, and here we have to have a full PPE, which involves having your N95 mask on the top of your standard PPE that you're going to use. So depending upon which situation or which area you're going to go, you can always decide what type of PPE you're going to use, and that helps us to keep handy some of our N95 masks or goggles or shields when we really need them. Okay, so let's start this video. Now, this is a video where we're going to go through the donning in the anesthetic room. Now, it is very important that you follow the steps whenever you are going to do the donning in the anesthetic room, as well as the doffing. The doffing is even more important because you have to follow the hand hygiene during each step of doffing. So this is the video that was created in our hospital, and these two of them, they are my colleagues who work at Sir Charles Gardner Hospital, and they've just started donning. So they start with hand hygiene, ensure that you've got a proper checklist, and then the gown goes first. The gown goes, and you've got a buddy, like a second person, who checks if you've been covered properly, front and back. Then goes the N95 mask, and if you've got if you got any spectacles, you can either use it or take it away. You perform the check. You perform the fit test. Let your buddy have a look at your fit test. You put the visor on, and then you put on the gloves. You have to have sterile gloves inside, which are long ones, and they can cover the sleeves of your gown. And then on the top of that, you can use the non-sterile gloves. So once you've done the donning, you just go through your checklist again, and you basically confirm that it's all good. Okay, So doffing. Now this is, as I said, is more important because these steps are very useful, and if they are done incorrectly, then there is a risk of contamination, that contamination of yourself or contamination of the surfaces around you. So when you start doffing, this is done in the dirty room, which we call as the operation theater, because that's where the patient has been managed, that's where the risk of aerosol is. So you start doffing in this dirty room. So you should have a hand sanitizer and a disposable bin where you're going to start your doffing. And it starts with taking out your gloves. So in this step, you can see that the first, the top gloves are removed by entering into the inside of the gloves. So you're not going to touch anything on the outside, and thus preventing any contamination of the rest of your PPE. And the same way, then you're going to take off the sterile gloves, put it in the bin, and then hand wash after every step. So once you've taken the gloves off, make sure that you're going to sanitize your hands. Once you've done the sanitization, you're going to take your gown. Be careful that you're not going to touch the front side of the gown, which is the contaminated part. And when you are removing the gown, you fold it inside out. So all the contaminated front part is basically folded inside, and that can be then disposed of. Again, meticulous hand hygiene is very important. And at this step, you're going to take off your visor and another hand hygiene before you're going to go into the clean room. Now, why do we still keep our mask, the N95 mask, until we go out of the operating theater? It's because of the aerosol, which can still be hanging in the operating theater for up to 3 hours. So just to prevent ourselves from getting contaminated or infected by the viruses, we go into the clean room, we close the door of the operating theater, take out our N95, and the next step is we're going to clean our hands. And this will be cleaning, proper cleaning, where you're using soap and water before you leave this room. Okay, so that's, your responsibility is not over when you've finished your doffing and you've left the operating theater. The most important thing is when you leave your hospital and you're going home, because that's the maximum risk where you can contaminate, or you can take these germs to your home or people around you. So what can you do? The basic things is you can use your wallet, your driver's license, or your mobiles, and put it in a Ziploc bag. If it's got a good tight seal, you can wash the Ziploc bag with either an antiseptic solution, or you can wash it with soap and water. Any equipment that you don't need at home, you should leave them in your office or in your hospital, where you can go back and use it again. Once you reach home, don't be, make sure that you're not going to get inside the house immediately. You take your shoes off. It's also advised that you should take your clothes off on the front door, put them in a bucket which is full of hot water. And once you've done that, you immediately go for a hot shower. And then once you come out, then you can get close to your family members. Okay, so that's about that's about PPE. So we're going to move on to the anesthetic management of patients during the COVID pandemic. So as we have seen during the conservation of the PPE, that we always treat these patients in different categories, where you're treating a patient who is a low risk for COVID positivity, or patients who are high risk or they are COVID positive, or you're going to enter into the areas where aerosolization is going to happen, like your ICU or operation theaters. So all the countries have their own guidelines. We've got the guidelines from the Australian Society of Anaesthesiologists, and these guidelines, they keep on getting updated every few days, because COVID, it's a dynamic process. It's a very labile time where the evidence keep on changing every day. So you have to stay up with the changing evidence and ensure that you're updating your protocols, your guidelines every day. So if you're going to do a low-risk patient during this pandemic, and if you have the facilities to check or to do a COVID test, and if it comes negative, you can just use your normal droplet precaution, routine care of the patient, just the standard PPE. And the important part is during extubation, you have to make sure that you minimize coughing, where if the patient is positive, you have to reduce any droplet contamination or aerosolization. Now, when you're going to the areas where airborne precaution is required, so like operating theater or in ICUs, now there you have to have your full PPE, but you have to plan everything according to the place where you're going to go. So this starts from admitting the patient, then transferring the patient from the ward to the theater, and then back from theater to the ward. You have to ensure that you're going to remove all the unnecessary items, and then have a specific plan for induction, intubation, and also the perioperative management of these patients. So what are the staff challenges here? Because this is the situation, we don't see it every day. We are used to our standard protocols, and we are very well versed with them. But in a situation where you have to use the PPE, which can slow you down, and also your patients are quite unwell, especially if they're COVID patients and they're quite sick. So there can be a variation to the normal workflow. You're working in unfamiliar working environments, like you might end up working in hospitals which you don't work regularly. You might go to the ICUs where you're coming across different professionals who are helping you during your procedures, like the ICU consultants, or you've got the different nurses coming there. You might not get your regular equipment, which you are used to. And finally, the patients are critically unwell, so they have a very limited physiologic reserve, and that can lead to a cardiovascular or respiratory collapse during induction, intubation, and the perioperative period. So this can create a lot of stress and fatigue for us during these times. So what can you do to get these procedures done easily, quickly, as well as reducing the risk of any infections? You have to practice. That's the most important thing, is you need to have a good practice session before you're going to manage a COVID positive patient. So you can run some simulations, have some dry runs. The most important thing is practicing donning and doffing. You should practice that yourself. You should practice that with your buddies who are going to help you during this during the patient management. And also you should have all the checklists ready. So checklists for donning, doffing, for your airway trolley, for your anesthetic machine, and also for any drugs or specific drugs that you're going to use. And the most important thing is you ensure that you've got a very good, clear, concise communication with the staff members you're going to work with. So we just briefly go through the theater preparation checklist. Now, the most important thing here is we have to have two different rooms. So one of them we call as the clean room, which is either the anesthetic room outside the operating theater. That's where all your clean equipment, your donning, and your anesthetic drugs and everything is kept, so that there is no contamination on, of any of these when you go inside the operating theater. You should also have a staff register sheet. Now, the reason you should have it is you have to look for who goes in and out of the operating theater, just to prevent any trespassing and the risk of transmission of the COVID virus. The second room, which is the dirty room, which is your operating theater, it should have, again, a proper checklist for the required equipment. It should have a checklist for what staff you should have inside the operating theater. You should have alert signs, like the COVID alert signs outside the operation theater. So people who are not following proper PPE are not going to enter into the operating room. Cheat sheets for everything, for induction, for intubation, for the drugs you're going to use, and also the emergency drugs during management of the patient. And communication with your staff, preparing your staff and giving them specific roles. So you should have a team of anesthetists where you are looking after the airway. You've got a colleague who is going to give the drugs. You have a technician who is going to hand you over the anesthetic equipment, and then there should be other nurses, runners, and orderlies. Before you enter into this dirty room or the operating theater, you have to ensure that you've emptied all the pockets and you have minimum number of people that are required for the management of the patient. So once you're in the operating theater and the patient arrives in the operating theater, he might be ventilating spontaneously. He's probably just got a face mask on him, a surgical mask, and or he might come with who is already intubated. He's coming from ICU. But then during this time, if he is not intubated, he might be still very agitated, combative due to hypoxia. And then he's getting high flow oxygen. So this can interact with each other if the patient coughs or sneezes, and there can be aerosol generation. So you have to ensure that you're properly dressed. You've got the N95 mask. Once the patient's PPE is removed, now you have to put the drips and IVs, so you have to get close to the patient. You might go and close to the patient's airway to assess, and during laryngoscopy and intubation, which is the most risky time for this aerosol generation. So the aerosol generating procedures in the operating theater is just the high flow oxygen or the gases we're going to give. If you are giving pre-oxygenation, you have to ensure a proper seal, and it can be quite difficult to get that proper seal, and that can lead to a leak, and also the droplets can get aerosolized. once you've intubated the patient or you're doing a non-invasive ventilation, and if there is any leak, that can again increase the risk of aerosolization. So to prevent all this, and especially during the laryngoscopy and intubation, the best way is to give a neuromuscular blockade to the patient. So during the airway manipulation, there is no coughing or any movement of the patient, and that will reduce the aerosolization. So you have certain protective strategies then. So you've already got your full PPE. You're going to use a good, well-fitting mask for the patient. You use the vice grip. Vice grip is just using both your hands on the top of the mask and ensuring a very good, proper seal. Once you've given the drugs, once you've given the neuromuscular blockade, avoid doing any positive pressure ventilation with your bag mask. And inflate always, once you've intubated the patient, make sure you inflate the cuff before you start ventilating. Have a closed system ready for your circuit. And one of the most important thing is a viral filter, which should be present between the endotracheal tube as well as the circuit to prevent any contamination of the inside part of the anesthetic machine. So there are other procedures when you're in the operating theater, apart from what you do is bronchoscopy or gastroscopies, and they are quite high risk for aerosol generation. So higher the duration of the procedure or aerosol generation, higher the risk of the viral load, and higher the risk of getting infected or contaminated. So what can you do? You should have a proper plan for your operating theater. You should get familiarized with your operating theater, where the patient's table is going to be, operating table, where the patient's head end is going to be, where you as a airway manager, where you're going to stand, where your anesthetic assistant, your colleague who is going to do the drugs, and also your anesthetic ventilator, monitor, and airway trolley. So, and that should be standard for all the patients that you are going to manage in the operating theater. So we'll just go through another video, again done, was created in our hospital. This is the one where you will see how we are managing the intubation. So once you're fully equipped, you've got full PPE, you're going to get into the operation theater, where only the essential staff is going to be. Ensure that you're not going to open the doors, and also you're going to check your video laryngoscopes, you're going to check your anesthetic machine. So again, confirm your protocol, intubation protocol before you start. Once you remove the surgical mask from the patient, you immediately put the mask on the patient's face. This is our mask for pre-oxygenation. Give the drugs, you do the laryngoscopy, should do it as a rapid sequence induction. And once intubated, the first thing you will do is inflate the cuff fully. And you have to keep a separate tray for all the instruments that you're going to use that are contaminated, so they can go for cleaning after the end of the procedure. So, so intubation is more standard. We know what you can accept or expect during the intubation time. But extubation can be quite dangerous because you might have a patient who's got severe chest infection and he might get agitated during the extubation time. He might start coughing and there can be splattering of all these droplets or aerosol around you. So have a plan for extubation. Like either you can extubate the patient very deep, so patient is breathing spontaneously, but you still extubate him quite deep, or just a standard extubation, but taking all the precaution. So the first step is always consider applying nasal prongs. So you keep on giving patient oxygenation during the extubation phase. Now here you can see that there is a special cutout plastic where you've got the face mask inside the plastic, and it's still connected to your circuit. So that goes on the patient's face to prevent any splattering of the sputum or the droplets. So so put it properly over the patient's face, and then you can extubate the patient if it's breathing spontaneously and you're happy with the reversal. And as quickly as possible, you should put the face mask on the patient's face. So once you've finished with your extubation, you've already given the patient nasal oxygen. You can, if you want, you can change it to a Hudson mask. If you're using nasal prongs, then you can use a normal surgical mask for the patient when you're going to transfer the patient from the operating theater to the ward. And if you're going to use a Hudson mask, then you should put a face visor for preventing any aerosolization during oxygenation of this patient. So this is about managing the patient in operating theater, where we're going to do a general anesthesia. And what about regional? So we do have the guidelines from, this one is from the Australian Society of Anaesthesiologists, and also some of the points are taken from the Royal College of Obstetricians and the Gynecologists. So regional anesthesia is very safe. If there is no contraindication, that should be the recommended intervention or anesthesia for the patient who is COVID positive. The only problem here is if the patient is unwell, if the patient has got some sepsis, then there is a risk of coagulopathy in these patients. So always have the coagulation profile of the latest coagulation profile of the patient handy, because if there is an increase in the INR, then you might have to avoid doing a neuromuscular blockade. And obstetric anesthesia, again, spinal epidural is very safe. There is no contraindication. There is a very low risk of vertical transmission of coronavirus from the mother to the baby. But still, to be on the safer side, what the RCOG has proposed is you should use, they've proposed that all the babies should be tested immediately after birth, and they should be followed for 14 days to monitor for any symptoms of COVID. Okay, so that's pretty much about the anesthetic. Let's quickly go through the key principles. You have to, in these days, you have to ensure that you're going to conserve your PPE. For that, you might have to reduce your elective surgery list. will only use the PPE for people who are going to be present close to the patient. Try to use your PPE for an extended period of time. So any PPE which is a single use, you should keep it on you for the whole day, because the moment you take it out, you have to have a new mask or you put a new gown. So you are, in that scenario, you're wasting a lot of your own PPE. So the only way you can do this is intensive training. You need to have early intervention of these patients so they have minimal risk from sepsis. You have a meticulous planning. You should be very vigilant about the infection control. There should be a very efficient airway management process, clear communication between your teams, and always use standardized practices. Okay, so that's pretty much about our PPE and anesthesia for COVID patient. And I'll say sorry to Saurabh, because initially it was planned for 10 minutes, but I'm sure I've probably gone a lot over the time that was allocated to me. But it's one of those topics which is very difficult to convey in 10 minutes. So sorry for the time, but I hope that might just help you when you're preparing yourself for managing the COVID patients either in the operating theater or managing patients in the ICU. So I'll hand over the mic to Saurabh or Amrusha for our next speaker to join.
Thank you, Dr. Chaitanya. We are not complaining about the time that you have exceeded. It was a really very informative session. And I think one of the most important things we got to understand here is that we need to do a lot of simulation-based practice, like you said, because we are not, till we are not immediately practicing this, it is important that we anticipate, practice, and practice. And another important thing that you've mentioned is about conserving PPE, because as we all know, the PPE is in absolutely short supply. So we really need to be careful about the PPE and how we are using it, and we're not using it where we don't need to use it. So thank you so much for that, Dr. Chaitanya. We'll move on to our next speaker now. Dr. Chaitanya, can you please take off the presentation?
I'll stop the sharing.
Yeah, thank you so much. Thank you.
No problems.
So next with us, we have our very own Mr. Know-It-All, Dr. Umesh Ramtani. He, after his MD in anesthesiology, he has done a fellowship in pain management from the Radia Pain Institute in Kolkata. He's presently working as an assistant professor in the Department of Anesthesiology, IGGMC Nagpur. He has been invited as a faculty at various national and state conferences. He is a vibrant member of the ISA NCB family and has worked incessantly creating public awareness and conducting BLS activities for healthcare professionals as well as for laymen. Over to you, Ramtani sir.
So hi everyone, am I audible?
Yes, you are.
So at the outset, I would like to thank and congratulate ISA Nagpur for this wonderful initiative conducting this webinar, the very first in this tenure and very first in this Corona era actually. In this lockdown period, this webinar has proved to be actually the good method of communicating and information sharing. So my topic of today is COVID operation theater disinfection and equipment decontamination. Is it seen on the screen?
Yes, we can see it.
So as far as this topic is concerned, Ministry of Health and Family Welfare, Government of India has designated Anaesthesiology branch as a core department dealing with this public health emergency crisis nowadays. So anesthesiologists are no more confined to providing the clinical services and anesthesia and critical services. Rather, the anesthesiologist plays a forefront role in dealing with this corona public health problem. Say it be administrative section or policy decisions or planning department, and as well as hospital infection control committee, because anesthesiologists as OT in charges are the important part of this committee, which is dealing with infection prevention and control. So as far as this public health global crisis is concerned, dealing with this corona COVID pandemic, our goal should be to break the chain of transmission. Basically, we have to deal with this problem along with the consideration in our mind about workplace safety. So workplace safety is very, very important mainstay of breaking the chain of transmission. So we have to set certain goals for this. And this goal should work in the team spirit, and that team spirit should include the organizational facility basically. So certain strategies are to be made, meticulous planning has to be done. Now, when we are dealing with COVID patients in operation theater, nowadays we are having so many asymptomatic patients who are in incubation period. They may come in, their report may come positive some later stage of the disease. So the guidelines say that we have to deal with every patient taking standard universal precautions. In that state, we have to set up certain policy, we have to set up certain SOPs to deal with these patients, and we have to consider the safety of the hospital, safety of the environment and healthcare settings. So we have to do a triage basically. What we have to do, we have to recognize these patients who are COVID suspects, who are high risk for this disease, and then we have to plan up the source control. So my talk goes on all these things, and these guidelines which I have taken are approved by Ministry of Health and Family Welfare, and these guidelines are decided upon environmental cleaning and disinfection and biomedical waste management. As already told by previous speaker, personal safety is absolutely important in these managing this pandemic patients. So hand hygiene, all the principles are given by WHO, how to rub your hands and how to wash your hands. All these protocols are well mentioned and well accepted. And we should be well versed with PPEs, what are the components, donning and doffing, which is already covered by the previous speaker. As far as Ministry of Government of India is concerned, an ICMR has proposed and recommended few disinfection methods, and moreover, the chemical methods are most approved in the COVID patients, in the COVID suspect and in the contaminating material. So basically, alcohol-based material solutions are available. Ethyl alcohol at the strength of 70 to 80% is approved, and isopropyl alcohol, which is a virucidal agent. So it is also approved in the strength of 20 to 40%. Chlorine-based solutions are most approved also, used in cleaning various environment surfaces, cleaning the equipments. So sodium hypochlorite in different strengths is available, which is 0.05%, 1% and 10%. Also hydrogen peroxide and superoxide based parasitic acids are also recommended in this setting. So general principles are to be followed. Basically, we have to reduce the majority of bioburden in the area, in the environment settings, to prevent the environmental contamination. And also, we have to disinfect the surfaces. Now, as far as these surfaces are concerned, there are two types of surfaces. One is minimal hand contact surface like floors, ceilings, walls, and other is high touch surfaces, which come into contact of our hand touch more and more frequently, like these fomites, which are the playing major role in transmission of coronavirus, like these doorknobs, light switches, wall areas, curtains, even some toilet handles and knobs of the toilet seats and all. And as far as anesthesia is concerned, our anesthesia gadgets, monitors, workstations, and airway equipments, these come into contact of our hands of health personnel, and that may play a role in transmission of infection actually. So we have to plan a certain guidelines for cleaning those all the areas, and we have to contain the environmental contamination. So generally, we divide the hospital settings into three areas. One is healthcare setting, which includes our operation theater, ICUs, and critical areas, and some non-healthcare settings like waiting rooms, pre-op rooms, and post-op rooms, and general settings which includes the hospital premises and waiting areas. So basically, we have to use neutral detergents, or we have to use isopropyl alcohol, ethanol, or sodium hypochlorite in different strengths. As far as textiles is concerned, we cannot use sodium hypochlorite because it may damage the linen and the laundry. So we can use washing machine and non-washing hot water cycles for cleaning those cloth material. The major difference is that when we are working in a healthcare setting, our health personnel should wear the proper PPE and consider personal safety. And as far as non-healthcare settings are concerned, we can use aprons, surgical masks, and some gloves. That will suffice. The non-critical medical equipments, as far as they are concerned, we cannot use sodium hypochlorite because it may damage the quality, like stethoscope, BP curves, thermometers. Only thing is we can use alcohol-based rubs and sanitizers and some detergent-based solutions. Even clean soap water will also work in the cleaning this non-critical medical equipment. As far as our OT is concerned, there is anesthesia room, anesthesia machines, some cauteries are there, laparoscopy trolleys there, other gadgets, defibrillators and monitors are there. In our institute, we have done barrier protection method. We use impervious transparent sheets, which we apply on the touch screen surfaces where we actually frequently touch the knobs and buttons. And we maintain that sheets and we clean those sheets with detergent solution above that. As far as training of staff is concerned, meticulous training and SOPs are needed in this handling with these equipment. Some checklist has to be followed. And if the procedures are going on in the theater or in the endoscopy rooms or in the laparoscopy rooms, then we have to plan accordingly and give the optimum time between the two procedures. And we have to maintain the checklist properly that we have cleaned this on which time and which date. Anesthesia equipment, so far, disposable equipments are preferable, but in some conditions, if we are not able to follow the disposable equipments, we are not able to use, then we have to sterilize them with the chemical methods. Strict theater cleaning policy has to be followed. As I've already told you, that when there are more than one or two procedures, the optimum interval should be kept between the two procedures for cleaning and sterilizing the things. In operating room, minimum number of health personnel and doctors should be allowed. Intermittent transit should be avoided. Doors should be closed once the patient is entering. If the OT is having high air exchange principles, so that should be maintained. High exchange cycles should be maintained, more than 25 cycles per hour. Negative pressure rooms are strongly recommended, but if it is not available, HEPA filters with high ventilation air conditioning system should be used, which we are using in our institute. Disposable items which are coming in contact with aerosol generating procedures should be disposed of. Non-disposable equipments like laryngoscopes, other monitors, other gadgets, they can be cleaned with sodium hypochlorite, 1.5% or 2 to 3% hydrogen peroxide. CO2 absorbers, definitely they should be changed after every case. Respiratory circuits should be thrown off. Stretchers, trolleys, and shifting beds, they should also be chemically carbolized by sodium hypochlorite. The staff should be properly trained in handling this all infected material after completion of the patient. If we are dealing with COVID suspects or COVID positive patients, we have to deal with this soiled linen, towels very efficiently and very thoroughly. Proper PPE should be worn, and this should be kept in leak-proof bags and containers. And ultimately, there should be labeling of these containers. We should not allow our staff to carry those containers on their back, because again, that will expose them. If we have a washing machine, we should use 60 to 90 degrees hot water cycling with laundry detergents. If we are not having machines, we can use drums. But again, we have to use stick for stirring it. We should not. We should train our personnel to have a minimum touch technique to the linen. And the area should be designated. When there should be a separate entry and exit room, exit door for the soiled area and the clean area. There should not be the intermixing between these two areas. And airflow should also be directed accordingly. Everything should be placed in its place, and there should be no intermixing allowed. There should be separate areas for soiled linen and the clean linen. Spills of body fluids, bloods, and other material during the operative procedure, they should be dealt with properly. Small spills can be dealt with hypochlorite 1%, but large spills, they should be absorbent material should be used for that, and 10% sodium hypochlorite will be useful in this case. Again, I say fumigation and unnecessary fogging will increase the aerosols, so that is not recommended. Visual alert should be kept in all the entire hospital premises with proper instructions to the health personnel, to the relatives, to the patients. Respiratory hygiene and cough etiquette should be properly followed. So these things are to be considered very importantly and very efficiently. Now to completely talk a word about biomedical waste management. Now as far as the principles are concerned, they are nonetheless similar to the other biomedical waste management protocols which are working in our hospital. But our staff, our technical staff, paramedics should be properly trained in all this handling of biomedical waste, especially in COVID patients, because we have to be more and more cautious and careful in these cases, because we should be properly trained in segregation, packaging, transportation and storage of these patients. And as far as possible, long storage duration should not be allowed. And we should be early disposing of all the biomedical waste related to the COVID patient. The similar guidelines are followed in the biomedical waste management disposal. All the color codings of bags and containers are to be properly followed. Only thing is proper labeling, proper symboling of the bags with the material labeled inside should be done, and extra precaution has to be taken to avoid the spillage of the biomedical waste, and proper entry and exit protocol should be followed in this case. As far as our center is concerned, it is a 600-bedded COVID center, surgical complex in Indira Gandhi Government Medical College, which is designated by authorities. Here we have theaters which are having HEPA filters with HVAC systems inside. Now you can see our anesthesia machines and gadgets all are covered by impervious plastic sheets. This is the patient transfer box, which has a oxygen delivery device attached to it. So patient is kept inside, and with the oxygen delivery system, it is kept inside and it is covered from all the sides. Even while handling him, there are globe packs inside attached to it. So this is used for transferring the patient from one ward to isolation ward to another if in case. This is the acrylic box, intubation box with sleeves of this sheet for personal protection, which we are using. And this is what I was talking about, that video laryngoscope MAGRA with disposable blades, which we are using. So this is perfect in the COVID patients because we dispose of this blade actually. And this is a steri air which we use in ICU wards of our COVID, SARI ward, which is a actually ward of COVID suspects. So this we are using. These all precautions we are taking in our institute. So our basic aim is to break the chain of transmission and to contain the source of infection at the very early level only, so as to not to convert it into a big outbreak. So I think enough from my side. I think my talk must have helped you understand the concept of environmental decontamination and equipment maintenance during the COVID era or pandemic. I want to thank Dr. Shilgaonkar Madam, Professor and Head of my department. It's because of all the joint efforts in our department, we are doing all these things and trying to tackle this problem as far as possible it is coming to us. So thank you from my side.
Thank you, Dr. Rampani. That was actually very helpful, and we got a lot of basics cleared on a lot of things. Thank you so much for that. So the questions are welcome from the audience. We already have some questions that have come in. Dr. Anand here wanted to ask Dr. Chaitanya, if you clamp the endotracheal tubes after inserting them to prevent aerosol generating procedures, to prevent basically generation of aerosols.
Yeah, we do clamp. So this is before we, so either once you've inflated the cuff, and the other thing is if you've got some time or you between connection of the endotracheal tube to your anesthetic circuit, you can clamp the tube, but it's quite difficult. If you clamp the tube during the extubation process, there is increased risk of cuffing and increased positive pressure inside the thoracic cavity that can increase the risk of aerosol generation.
Okay. And talking about that, in the ICU, do you prefer using NIV in your patients, or would you rather go invasive?
Look, most of the patients do well with invasive ventilation. We do NIVs in our hospital, but then if you're doing NIV, it has to be in an isolated negative pressure room. If you do it in an open area, then the risk of contaminating other patients or staff is quite high.
Okay. Okay. So, Dr. Harkari here wants to know if there are any other filters that you use to attach to your circuits. Someone else also had a similar question that the normal filters that we use take care of 99% of the bacteria and viruses. Are there any other filters that you're using apart from the usual HME filters?
We're using the usual HME filters, but then there are different companies that make them. So we've got the Dragger ones, we've got the Pegasus ones, and they actually do the same kind of protection.
Okay, okay. Next, we have from Dr. Madankar, who is asking that he talks about doffing being more important than donning. Absolutely. And if you would prefer to have a dedicated person who looks over while the doffing is going on.
Yeah, you can have a person who is who's got a checklist in his hand. But once you are used to the doffing process itself, when you have a cheat sheet next to you and you have practiced it before, I think it just becomes your second nature then. And then basically the most important thing there is to follow the hand hygiene every time after you start taking off the equipment.
Right, right. Dr. Hina wants to know if you take any additional care during your laparoscopic procedures. And someone else wants to know what are the other aerosol generating procedures pertaining to the surgeries apart from bronchoscopies and the upper GI scopies as well. Would you include them as well, the upper GI scopies in your
these are called as the aerodigestive procedures, where there is an increased aerosolization during these procedures. But any procedure on the head and neck, where there is going to be a lot of suctioning, if you're going to do a tracheostomy, certain head and neck procedures, especially around the ear or the intracranial sort of tumors, they all can increase the risk of aerosolization, as well as your laparoscopic procedures. But the amount of the virus load found outside the digestive system is very low. So unless you are going to puncture the digestive system where you might have any fluid that's going to come out, the risk of aerosolization is very low. And again, it's quite well contained, and you've got a suction in there, so that can all be sucked out efficiently.
Right. So there is no harm in going ahead with laparoscopic procedures in these cases.
So what happens is with any of these procedures, the risk of infection or the contamination is directly proportional to the duration of the procedure itself. So especially for the aerodigestive procedures. So any procedure where aerosolization can occur, especially the surgical procedure, the risk of contamination rises exponentially from 15 minutes onwards. So normally we try to keep that as less as possible by ensuring that we've got the correct surgeons who are very well experienced and can minimize the time during surgery.
Right. Right.
Madam Chaitanya, I'd like to make a point here.
Yes, sir.
So procedures. I hope you will agree with me that at this point of development, laparoscopic procedures are not highly recommended, because we should not give this message to the house that laparoscopic procedures are not harmful. There is a big debate going on that if possible, go for open surgical procedures, and definitely there is certain risk with laparoscopic procedure. What is your take on that, Dr. Chaitanya?
Look, Again, this is there is no the right or wrong answer here, and there is a lot of discussion that's going around. I think the surgical colleges, they have come up with their guideline, and I probably would refer to the guidelines that are written by say the Royal College of Surgeons, and just go through them to ensure whether which is more safer in this era at the moment with the COVID pandemic. But I think both laparoscopic procedures and open procedures, they have similar risks. Only thing is, when you're doing it as an open procedure, it's a quicker operation, and that sort of duration of exposure is limited.
Yes. So though COVID has taught us to be highly flexible, and it's a very dynamic thing, what was wrong yesterday is right today, and what was right yesterday is wrong today. So we should definitely wait for it. As far as the heat and moisture exchanger with viral filters are there, the question asked by one of the panelists or the audience is right. In India, we are recommending that you use 3 heat and moisture exchanger with viral filters. One on the expiratory limb of the closed circuit, and secondly on the on the inspiratory one, and third one on the tube itself. So rather than that adds on to need for doing the clamping. So you can avoid clamping of the tube if you got an HMEF heat and moisture exchanger with viral filter over the tube itself. But yes, once you do the intubation, you may find it slightly heavy and cumbersome to intubate. Third thing was about the PPE kits which you have used and demonstrated in your videos. In India, we are not using that type of kits for very sure. We use it with shoe covers, and we use it with head hood. Head hood are of 2 types, whether of nun type or of jacket type. So we are using rigidly following the use of shoe covers as well as head hood. So can you please comment on that?
Yeah. So so with all the evidence that has come through from some different parts of the world, where there was the evidence or the paper that came from Singapore, US, and Hong Kong, and all of them have shown that using the shoe cover, if it's not disposed properly during doffing, that's the highest risk of causing any infection or contamination. And if you don't use it in a day-to-day practice for managing the COVID patients, the risk of getting exposed to the germs is quite low, because you're going to do a proper sort of cleanup after the procedure itself. So you're going to use the shoes, which will be more or less like plastic shoes, and your gown is long enough, so you get protected thoroughly, even if you're not using.
And Dr. Chaitanya, I'd like to interrupt you here right itself. In your video, you have not shown the use of shoe covers at all.
Yeah, that's right. So we don't use them.
No, but as far as RCO guidelines are concerned, or whether WSA guidelines are concerned, or ASA guidelines are concerned, in that PPE kits and people actually working in COVID OTs in UK and US, they are using, see what happens is we may not get carried away and be relaxed and lax, because in India the numbers are going up gradually, and we have to be, and hospitals are getting closed like anything. In Maharashtra, Mumbai, only 3 hospitals were closed, and around 200 hospital staff was quarantined. So I think we are in the phase where we should follow the appropriate and rigid use of PPEs to protect ourselves also, and as well as other patients also. Agreed, the number of patients with COVID positive confirmed coming for surgical procedures is less, but so we can rationally use personal protective equipments. And what is your take on negative pressure OTs?
Look, it's not available everywhere. Where there are certain operation theaters which can be converted from positive pressure to negative pressures, or some of the positive pressure OTs where you can reduce the positive pressures so reduce the flow of the air from inside the operating theater to the clean room or outside the operation theater. So if you've got a negative pressure room, that's the best sort of operation theater where you can do all your COVID related procedures. But if you don't have, then as Dr. Ramtani has mentioned, you have to have proper guidelines of cleaning the operating theater before the next patient comes in.
I understand that making a theater instead of negatively pressurized, making it a neutrally pressurized. Rather, if not from positive to make it neutral,
right.
If not
neutral pressure.
But if suppose that is not available, are you using air conditioning system in your OTs there?
No. So in that case, we have we just follow the protocols of minimal opening of the rooms. We have in between the clean OT, the clean room and the dirty room or the operation theater. We have a connection or a box where we can transfer certain instruments or drugs when required. So we don't have to open the doors until the end of the procedure.
What do you do with the air conditioning?
Look, we do, if the surgeons are very adamant, we still leave it on, but we can shut it off if required for the shorter procedures.
Okay, thank you.
So talking about the AC, are there any guidelines about having the centralized ACs? How should they be? Should they be put off, or is it okay if there are adequate, like 10 to 12 air changes per hour with the existing air conditioning system? Is it okay if we still keep the centralized ACs on, or should we put it off?
Madam, as far as central air conditioning is concerned, because it is linked to the other OTs or other areas of the hospital. So that poses a threat of virus being carried over and circulated to the wherever the central air conditioning is going. So as of now, clear-cut guidelines from Ministry of Health and Family Welfare and ICMR are to keep the central air conditioned off. If it is, you can keep it on if it is catering to that particular area only. If it is catering to the COVID isolation ward or COVID ICU or COVID OT, then only it can be kept on. If it is in India, usually central air conditioning is catering to multiple areas. One. Two is people have added on, because it's those who have worn the PPEs, they can understand that you sweat a lot, you are drenched with sweat, you want to take water, you cannot take the water. And yes, back-to-back surgeries are not being done right now and hopefully may not be required. But if at all we have to do back-to-back surgeries, they are very, very cumbersome. So what people have done is that they have applied split ACs, and the air which is drawn is filtered through the high efficiency particulate air filters, and some are using exhaust fans also to decrease the viral load in the OTs. But use of exhaust fans is a double-edged sword, because you have to ensure that there is no adjoining building, no adjoining medical personnel near the COVID OTs. So the recommendation right now going is that preferably have the COVID OTs on the topmost floor of your hospital or the block, and there should not be no adjoining building near that one.
Right, sir. Thank you, sir. Dr. Lavangi wants to know if it is mandatory to wear PPE kits even for minimally invasive procedures in non-COVID patients.
If the patients have been tested and they are negative, then you can just use standard precautions. But just you have to be extra careful during these times. And this all comes down to the conservation of PPE, because if you use all your PPE for low-risk patients, then you might not have enough when you really want it.
Okay, absolutely.
I'll add on to Dr. Chaitanya. Dr. Chaitanya, Indian Society of Anaesthesiologists has issued this advisory to all its members to wear N95 and face shields during all anesthetic procedures. It was carefully thought of, and then this advisory was issued, and there was some discussions about regional anesthesia and general anesthesia. But after discussions, it was found that even doing regional anesthesia also, because of the surgical procedures also, nowadays in India, only emergency surgeries or maximum semi-emergency surgeries are being done, like cesarean section, hematoperitoneum, perforation peritonitis requiring exploration. Elective surgeries are banned by Ministry of Health and Family Welfare, Ministry of Home Affairs, and ICMR during the lockdown interval. So for these emergency surgical procedures, which are COVID negative or there is no suspicion, all anesthesiologists are advised to use FFP2 or N95 and face shields, because even during regional anesthesia, patient can have slightly higher level of spinal anesthesia with hypotension, with associated vomiting, and patient can cough also. Even if there is some peritoneal irritation, that time also patient can cough. So please, we are strictly advising our anesthesiologists, please don't think that during regional anesthesia, there is less risk to you than general anesthesia. With general anesthesia, it is an enhanced AGMP, enhanced aerosol generating medical procedure. So please go for enhanced precautions, but don't get lax with spinal anesthesia. Spinal anesthesia, clear cut telling it to all our colleagues in the OT that this COVID-19 exposure is not for anesthesiologists only. There is no debate. We are talking to all the other surgical specialties of India, whether it is orthopedics or general surgery or ENT or eye or endoscopic surgeries, gastroenterologists, surgical gastroenterologists, that there is no debate on anesthesiologists versus surgical specialties. All those who are present inside the OT are at an equal risk, whether it is the surgeons, anesthesiologists, nurses, bearers, or sweepers. So appropriate level of precautions in a non-COVID patients has to be taken by everybody, like ENT surgeons. Though they are not doing any elective surgery right now, but we are advising them also in our informal discussions. So as of now, our position statement is elective surgery not to be done in the lockdown period. Emergency surgeries, COVID negative, use N95 and face shields. Highly suspicious patient and surgery can wait, go for COVID testing. If COVID positive, refer to the centers where such facilities
can I just add on here, is because policies are made according to the different countries where you have the COVID patients. Now, in Perth, the number of contamination or in the general public or community is next to negligible. So for us, when we are managing these patients, the low-risk patients, we're quite sure that these patients are definitely or are almost COVID negative. But as you said, that patient, in India or in the US or anywhere, there is a high risk of contamination of the general population in the community. Then you have to have a full PPE even if you're doing emergency anesthesia for a patient who is not symptomatic or who has not been tested or who is possibly negative on screening because he might be in that incubation period. So it all comes down to the community spread within your area or within your state or the country. So what we do is we keep on evaluating and keep updating our guidelines. So initially when we started, we definitely had PPE for all our emergency procedures, even if the patients were COVID negative. But then gradually as we started to know, we had all the testing within the community. It was absolutely zero spread of the virus. Then we had to upgrade our protocols. And that's again for, and you save a lot of money as well. And the risk of using the PPE, it does slow down you. It does sort of slow down you during the emergency events that might be happening. So if you don't have to use it, you shouldn't use it. But in situations where there is definitely high risk, you should protect yourself. And by protecting yourself, you're also protecting people around you and and people in your house, your family members, and your friends. So yeah, I definitely agree with that.
Exactly. Thank you.
So if I can draw a corollary from both your discussions, so to create a balance between protecting ourselves and conserving the PPE, what we can do is have a minimum for the anesthetists. We can have a minimum of N95 masks and gloves when they are inside the OT, and they can reuse their N95 mask according to the guidelines that have been coming up in our country, like using say 5 N95 masks for 20 days. We can use it up to 4 times. So maybe that could be some balance midway that we can achieve.
Yeah, definitely.
Okay, and we have got a good question.
But madam, use face shields also. See, face shields also add on to the protection.
Right, and we can absolutely reduce them.
It is always better to be on a safer side rather than having 20-30 medical personnel being quarantined at a time. Absolutely. And putting their family members at risk. It is a small thing, and it's always added on.
Yeah, and we can just
it's really important to keep on following your institutional or the area guidelines, which are updated every couple of days.
Yeah.
Right. So another good question we have here is, at the end of each procedure with the COVID patient, should we change the soda lime every time?
Yes.
I might ask Umesh to answer that because of his command over the basically decontamination of all the anesthesia machines and the OT. So probably I would ask Umesh to answer that question.
Thank you, sir. First of all,
Dr. Ramtani,
I've already covered in my presentation that CO2 absorbers have already to be replaced. I've already covered in my presentation that after every case, CO2 absorber has to be replaced, and breathing circuits and all the disposable things we have to dispose of so far, as far possible.
Right. Sorry, missed that. Okay. Another one coming from Dr. Shimbekar is if we have any recommendations for patient rooms. I'm not sure what ma'am exactly means here.
Patient room?
Patient rooms, the patient, whether these positive patients are being kept or where they are being isolated.
In our institute, what we are doing in our institute, if we are keeping the positive patients, there is a separate positive ward which has cabinets, each for each patient. Okay. So I think, I don't know what ma'am wants to know.
About disinfections. She wants to know about the disinfection of the patient rooms.
So disinfection principles are to be followed again in the similar lines as operative rooms are concerned. Once the patient is discharged, once the patient is shifted from that, we have to follow the chemical methods only for cleaning all the beds, and the linen we have to treat accordingly. All the IV sets or IV stands or whatever material is inside that cabinet, we have to clean it with the chemical methods only. Even the ambulance cleaning methods are also given as per the guidelines of Ministry of Health and Family Welfare. Even the ambulance which is used for transiting the patient from one place to another place, and if the patient is suspect or patient is positive, we have to clean every corner of ambulance. All the guidelines are given how to clean those ambulance things, and even the drawers we have to clean. In drawers of the patient which we is using, suppose the drug trolleys or the side trolleys which are kept in the ward, that also we have to sterilize with the chemical carbolization method after the discharge of the patient.
Thank you, Umesh, for a nice reply. Can I ask one question to you? Yes, you're very right that for all metallic and hard surfaces we have to use alcohol, and for all surfaces, floors, walls, we have to use 1% chloride. Are you using hydrogen peroxide?
No, in our institute we are not using, but it is recommended that hydrogen peroxide can be used in either the powder form for cleaning the surfaces.
I agree with you. See, it is recommended that 2 to 3% of hydrogen peroxide, VHP, vaporized hydrogen peroxide generator, VHPG machine is there, but it is costing 70 lakh rupees, to be honest, 40 to 50 lakh rupees. So that has to be procured as per institute policy, and we are also in the process of buying it, and along with the plasma sterilizer for the reuse of N95. So, but these are things which cost and gradually will come in the institutes.
Even glutaraldehyde is we cannot use because of the cost factor only, and also another factor.
It is very costly than
sodium hypochlorite.
Right, it is very costly.
And also the contact period required for glutaraldehyde is longer. Means we have to keep the instrument for 6 to 8 hours.
Yes, this is half an hour. Half an hour should be sufficient. Hydrochloride half an hour should be sufficient. So hydrogen peroxide is ideal, but machine is being procured.
So I think the key point here is most of the transmission of the infection happens through the contact from the surfaces and the fomites. So so there are larger healthcare workers who are at risk, and that's why, as you mentioned that you have to make sure that you keep on decontaminating all these surfaces, metal surfaces, very regularly, and when the patients are inside a closed space.
And ensure that you are minimally touching the surfaces and equipment.
Absolutely, yeah.
We have one question here for Dr. Naveen Malhotra coming from Dr. Chaitanya Tak. If preoperative testing for patients coming for all surgeries for COVID should be done, are there any guidelines that are going to be announced?
Multi-million-dollar question asked to me. Yes, I confess, and we have been in touch regularly with ICMR, Ministry of Health and Family Welfare, and different associations also. There is a big discussions going on regarding having COVID-19 testing as a part of preoperative testing. I have intentionally not used the word pre-anesthetic testing, because I want to ensure and hammer onto all administrators and bureaucrats and other association presidents and secretaries that this is not a part of pre-anesthetic investigation. It is a part of pre-operative investigation. So I request all of you also, if COVID testing is a part of pre-operative testing like HIV, HBS and HCV. Sooner or later, what I can speculate right now is, we have calculated the number of surgeries being done per day, emergency surgeries being done per day in India, rough estimates. And if lockdown opens, expected number of surgeries to be done electively. So that much testing facilities as of now are not available. But yes, there is a discussion and thought process going on in including perioperative testing for COVID, like HBS, HCV, and HIV. And we are telling them, yes, the cost of PPE in using all the surgical procedures, thinking them they are positive is much more than testing. But issue is practical is that the number of kits being developed. But yes, I can share with you, thought process is going at the highest level and we are actively involved. Right now, in next 1 or 2 days, SOPs for COVID OTs will be released, and SOPs for non-COVID patients are in final stages. Once we concur with ICMR and Ministry of Health and Family Welfare, I am personally involved in that. We will be.
Okay. So I believe here, sir, the problem with preoperative testing would be that we don't have a test with good sensitivity. So just getting one swab negative will not give us a very high knowledge, very definite knowledge whether our patient is really negative or not. And we might just become lax thinking that the patient is negative when we are really, we cannot really be sure whether the patient is negative or positive. Right, sir?
All these things are going on in discussions, madam. The sensitivity and specificity of the test, the not much reliability of the antibody test, but this gene to me is coming, which is saying they are claiming that they will give reports in 30 minutes or so. Madam, all these things are actively being discussed. It is a national pandemic, and we have to be keep in mind the resources also and safety also. But at that's why the advisory is very clear from Ministry of Health and Family Welfare that no elective surgery during lockdown. So that is why that otherwise there was some relaxation going to be given from 20th, but that is why that thing is there. Okay. Only relaxation which has been extended is for oncosurgery. Those where staging of the malignancy can be adversely affected if surgery is delayed. So as of now, only emergency surgeries and those oncosurgeries where delay can affect the staging adversely.
Right, sir. So we have just a couple of final questions coming from the audience. If we would like to have, we would recommend a chest X-ray or an HRCT chest routinely for a non-COVID patient who's coming for an emergency surgery.
I think if the patient is not symptomatic and he is otherwise pretty well, it is not a sort of a mandatory investigation where you will be doing. But if there are any symptoms, because some of the patients who are coming with COVID positive, who are coming as COVID positive, they might look pretty relaxed. They don't have any shortness of breath. Then you do their saturations, which are quite low. So we don't know why that happens, but at that stage, they have already started getting the chest infection. And in those patients, if somebody has low saturation, even if he from externally is appearing fine, I think you should go for chest X-ray and CT scans or HRCTs.
Right. Okay.
And I can add to him that now the use of pocket pulse oximeter will increase. Everybody will be, in addition to the clinical signs and symptoms of the respiratory distress, all anesthesiologists will carry those finger pulse oximeters in their pocket and do check the oxygen saturation of all the patients.
Right, sir. What about OT contamination in OTs which are not having AGSS? This is the question coming from Dr. Alsi.
Not having
AGSS, the scavenging, the anesthetic gas scavenging systems.
See, madam, we have to be very, very practical. Active scavenging in India, in majority of the OTs, is not there. Active scavenging system is not there. Few modular OTs have active scavenging system. So that is why use of these 3 filters, use of closed circuit, use of low flow anesthesia, and one trick which we have followed is that in the exhaust port of the machine, we have put a corrugated tubing and we have dipped it in a bucket with a hypochlorite solution. So we are following many things. One is 3 HEMEF filters, low flow anesthesia, use of absolutely closed circuit with low flow anesthesia, and then dipping the exhaust port gases into 1% of hypochlorite solution. That is a trick which you can follow. But active scavenging, I confess, in my institute was not there, is not there.
Yeah. So that's what. So this is something where it changes from place to place, and this, there is nothing in our protocol where we are talking about the scavenging, because pretty much each and every OT is actively scavenged. So this was a very good question, and what Dr. Lavang answered in terms of if you don't have scavenging, what you should do. So that was very informative for me as well.
Thank you.
Okay. Saurabh sir, do you have any questions?
No. I think we have done